everyone. So I would like to welcome you today for Leukemia Management webinar, which is organized by SSBD with unrestricted fund from Pfizer. I would like to welcome the 65 attendees who joined us now, and I would like also to thank our faculty experts, Prof. Wendy who's joining us from University of Chicago, Dr. Naif Aljohani from King Faisal Special Hospital, and Dr. Murtadha Alkhabori from Sultan Qaboos University Hospital. So as you know that COVID-19 is becoming a global pandemic, and this is a statistic today in Saudi Arabia. There are currently almost 5,000 cases diagnosed with COVID-19. In GCC, the total number is 10,700 cases, with an overall mortality of 6.1. This is worldwide. Total number of cases is 1.8 million cases globally. So this is affecting the care that we can provide for our patients, specifically the leukemia patient. So we'll try to address this today. And in the program, we will have Dr. Murtadha Alkhabori, who will be talking about CML management during COVID. And then we'll have Dr. Naif Aljohani to address AML management during COVID. And Dr. Wendy, she will talk about ALL in general. And then she will touch base on how to manage ALL during COVID-19. So without any further ado, I will ask Dr. Murtadha Alkhabori to start his first talk. And before we start, I will just ask the attendees, if you have a question, please post it in the Q&A section, not in the chat. Thank you, Dr. Murtadha.
Assalamu alaikum. Good morning, good evening, everyone. First, I would like to thank Feras and his organizing committee for the invitation. Now I'll try to share my slide. So my slide can be seen, right?
Yes.
So yeah, in the next 15 minutes or so, I'll try to cover the management of CML during COVID-19. It's only the changes that we need to consider during the COVID-19 pandemics. First, I'll talk about the risk of getting COVID-19 in patients with CML in our region, symptoms of COVID-19 in patients with CML, impact on monitoring and therapy for CML infections, of medications of COVID-19 and CML medications, the non-direct impact of COVID-19 on patients with CML, and patients with CML enrolled in clinical trials. As it's only 15 minutes, it would be a slide or so on each of these questions. Now, to understand to try to estimate the impact of COVID-19 or the probability of getting COVID-19 in our CML patient, we need to understand the size of the problem in the region. As Feras has already alluded, it's getting into close to thousands in some countries and close to 1,000 in Oman. Those are the epi curves, the epidemiology curves of the 6 countries in the GCC region. As you can see, the kinetics are different, and the way we reach the apex, or the so-called apex, is different. But overall, the risk of getting COVID-19 in the general population is about 1 in 10,000. Now, if you think of that risk, you are probably unlikely to see patients with CML with COVID-19. The problem, this is likely an underestimate. We know there is a significant proportion of patients with, we are still not at the apex, so it's likely to increase, as you can see from the curves. Now, to try to estimate that risk, we start with 1 in 10,000, and then you factor in the other factors that increase the risk. And if you think the risk would be increased for either the symptomatic, the under-testing, the fact that we did not reach the apex, and maybe the increased risk of getting COVID-19 in patients who have a bone marrow disorder or on potentially immunosuppression, then if you assume that we would get to 100-fold increase, the risk would be still 1 in 100. So it is not that high, but you would definitely at that time, I mean, consider the risk. You will get, if your size of CML patients is 100, so you would likely to see at least one patient with CML. Now, there is, as of yet, no data to suggest that patients with CML at a higher risk of getting COVID-19, neither due to their CML, nor because of the tyrosine kinase inhibitor. But if you think of it, the patient with CML, when they stay at home, they are outside that susceptible population. So this is why they don't contribute to the curve getting to the apex. If they come to your clinic, then they leave home and they're at risk of getting COVID-19. So that is, you cannot factor in the prediction of the increased risk. Additionally, most of us would have CML clinics. So if you have a patient with CML, the likelihood that other patients with CML would also get it if they attend the same clinic. So the probability of getting COVID-19 is not independent between CML patients. Now, this is to do with the risk of getting COVID-19. Now, if a patient with CML getting COVID-19, what are the risk of complications, getting complications from COVID-19? One, we know this population is associated with older age, and that is a risk factor of getting complications. Plus, many of them would have comorbidities, and that would also increase their risk of getting complications of COVID-19. One peculiar reason, one peculiar distribution of age in our region, that we have CML of a younger population and without comorbidities. The good thing from the results of the Hubei epidemic, we know that there were very few CML patients and their outcomes were very similar to the general population. So to some extent, there is some reassurance that if patient with CML get COVID-19, then there is no increased risk of complications. Now, what are the similarities or differences of symptoms of COVID-19 or CML or the medications of CML? There is no suggestion, again, that symptoms are different than in general population. The tyrosine kinase inhibitors are unlikely to change the symptomatology of COVID-19 presentation in patients with CML. But there may be some characteristics in CML. One, the pleural effusion that is associated with the dasatinib. If a patient on dasatinib or any other tyrosine kinase inhibitor gets a pleural effusion, now this could be because of COVID-19, however you expect them to be sick at that time, or because of the dasatinib. The management as such would be the same as the standard management for pleural effusion on dasatinib. Here, you probably would argue for testing. Most of the case definitions in our region would still require patients to be symptomatology, and this may not fulfill the definition. However, I think most of the ID teams in our region would be flexible of getting those tested. And then the muscle aches and pains that patients get when you start them on tyrosine kinase inhibitor that are similar to the flu-like symptoms. However, this is usually not associated with fever. And again, if a patient gets it, especially if he's been or she's been on the tyrosine kinase inhibitor for some time, I would argue for testing. Now, the other risk is the pulmonary hypertension that is associated with some of the medications, again, like the dasatinib. If a patient with CML on dasatinib gets COVID-19, the subclinical pulmonary arterial hypertension may become clinical, and one should consider this in the management of those patients. Now, how does COVID-19 affect or impacts the monitoring, molecular monitoring in patients with CML? Overall, those patients in our region or in most regions will get tested every 3 to 6 months. Now, 3 months is a relatively long period for hopefully the the duration of this pandemic. Hopefully this pandemic would not last for more than 3 months. It's likely to turn into an endemic, but the size would be hopefully lower. The things that people suggest is consider remote testing. If a testing can be done while the patient in his region, or she's in her region, that would be the best. Or consider less frequent testing in patients with deep molecular responses. Now, when you see patients that you've already started on a TFR trial, we don't know the impact of COVID-19 on the outcomes of the TFR. We know one of the reasons why patients stay in TFR while they're off TKIs is the immunosurveillance, and we know severe viral infections can change that immunosurveillance. So it would be interesting to know in those patients who have been started on TFR, what happens if they get COVID-19. But we know the risk of molecular relapse is high, and the decreased frequency of testing in those patients is probably not advisable. So if you did not try it in patients and patients eligible, probably it is wise to wait for those patients till this epidemic is over, and then try the TFR trial. Again, you consider remote testing if you can do it for those patients. But again, it would be difficult to decrease the frequency of testing in patients on a TFR trial. Now, does COVID-19 change the choice of therapy in patients with CML? Probably no. No impact on treatment choice. However, as you start those patients, we know there may be a period of myelosuppression that patients get. And this needs to be really observed, either with more frequent CBCs, frequent support with GCSF. Again, consider remote testing with CBC, maybe to a center close at home rather than coming to the CML center. The therapy should not be stopped in patients who get COVID-19, who don't have severe COVID-19 infection. However, if it's a bad COVID-19 infection and the patient is admitted or in ICU, I think, and the recommendation is to consider cessation of therapy, or at least holding the therapy, but the situation should be discussed case-to-case basis. In patients who have a blast phase, most of us would try them or start them on combination chemotherapy. Now, given the expected myelosuppression with the combination chemotherapy, and maybe in the next few weeks, while we don't know where those epicurves are heading, one should consider a single agent for those who have advanced phase. However, this should not be very long, because we know this response is usually temporary, and they progress and lose response fast. The next question is there any interaction between CML treatment and therapies now suggested for COVID-19? So far, we have a number of therapies suggested and off-label use for COVID-19, or some of them are in clinical trials. One of them is hydroxychloroquine. Now, hydroxychloroquine, we know has no impact on the P450 enzyme system. That means it's unlikely to interact with imatinib. Actually, and interestingly, a recently published study that looked at adding hydroxychloroquine to patients on imatinib, not to see whether they have less risk of COVID-19, but to try to improve their responses. And in those patients, the combination was well tolerated. So there is no interaction between hydroxychloroquine and the tyrosine kinase inhibitors, and it's likely to be well tolerated in patients taking imatinib. Now, a word of caution here: hydroxychloroquine and azithromycin both cause prolongation of the QT, and this should be closely monitored if you set patients on the combination. There is no known drug interaction or metabolism or transport effect with the tyrosine kinase inhibitor and the antiviral remdesivir. And there is also no interaction expected with the convalescent plasma, which most of us, I'm sure, trying to prepare for COVID-19 patients. Now, there is a big non-direct impact of COVID-19 in patients with CML. So one of the things that we probably most of us faced is the lockdown. Some of the regions, especially the capital, where like we see more cases. Now you cannot travel from your region or your wilaya to the place where you get your tyrosine kinase inhibitors, and this has led to some patients not being able to get a refill of their medications, and some of them actually missed their medications. Now most of us started early with preparing for this, and they tried to create a system by one way or the other of getting those medications to patients, even if they cannot travel to your region. And then the travel restrictions with the cargo restrictions, the priorities goes to the priorities, and then getting the medications, if you don't have good stock, maybe also impact. So the availability of the tyrosine kinase inhibitors as the other important medications for our leukemic patients and other hematological malignancies may be also affected. One thing that most of the patients may feel fear of is the fact that they have a chronic condition. And people say if you have COVID-19 and a chronic condition, that increases your risk of complications. Now, as we previously indicated, that those patients don't have higher risk. And I think in our encounter with either remote clinics or virtual clinics that we do is to try to assure those patients. The other thing is when it comes to really bad, when like you have to prioritize for life-saving interventions, hopefully we will not get there, is you'd have to prioritize on some sort of a score. And when you see leukemic patients with bad COVID-19 and you see another young patient who have only COVID-19, those patients may be prioritized over the patient with leukemia. And I think it's important here that we educate the other physicians in emergency and in internal medicine and in ICU that the outcome of patient with CML is almost close to the general population. And then the last thing is the economic impact and the availability of state-of-art tyrosine kinase inhibitors. The COVID-19 has significantly impacted most of us. And there will be major restrictions after COVID-19 trying to catch up with the major impact on economy. There should be a contribution from pharma here that they need to lower the medications, the cost of the medications, to try to facilitate the continuation of the same standard of care. Otherwise, like centers would seriously consider going to generic imatinib, going to first generation tyrosine kinase inhibitors in all patients with CML, although most of us would choose that even in the current situation. The last issue I want to discuss is patients with CML enrolled clinical trials. Now, the recommendations here are the general recommendations for all patients in clinical trials. The principle is try to decrease the risk in patients coming to centers where you treat COVID-19. You try to keep them outside that susceptible population. And also you want to decrease the workload on your hospital. You want to keep the staff busy for COVID-19 management. So consider not to enroll new patients into clinical trials unless the intervention in that clinical trial is life-saving. Also consider changing the physical visits to remote visits, including the virtual visits, if this will not affect the integrity of the trials. Now, there will be a lot of deviations here, but I think ethics committees would understand the reasons for deviations. Also consider remote test and home delivery of medications, either in standard of care or specifically here in the clinical trials. And consider stopping studies if you just started or they're almost close to the end, where the integrity of the trial will not be affected if you stop it either early or at the end. Of course, if you stop it early, you would have to restart it after the pandemic is over. So the take-home messages here, the risk of getting COVID-19 in patients with CML is currently low. However, the situation is very dynamic, and we likely will end up with at least 1 or 2 patients with CML with COVID-19. Patients with CML should observe the general recommendation for the general population, especially if they have high-risk features like age and comorbidities for COVID-19 complications. Test for COVID-19 in patients with pleural effusions and treat as per standard approach. So far, there are no impact on the treatment choice, but observed for myelosuppression if you start patients on newly diagnosed patients on tyrosine kinase inhibitors. There is no major interaction between the tyrosine kinase inhibitors and possible COVID-19 therapies, except for the prolongation of the QTC, which should be clearly observed. Try to minimize the non-direct impact of the COVID-19 and consider remote visits, tests, and home drug delivery for patients who are enrolled in clinical trials or even standards of care who live far from the CML center. And with that, again, I would like to thank the organizing committee for the invitation. I'm happy to take any questions.
Thank you, Dr. Murtadha, for an excellent talk. I'll just take one question from the audience, and then we'll leave the rest at the end. So Dr. Haytham Al-Jabbar is asking, some TKIs, specifically imatinib and neratinib, are known to be prothrombotic. Will this change the management? I mean, for new patient, or will you change the management for those who are in those TKI? Will you consider adding anticoagulants for those who are in imatinib or neratinib? And thank you.
Yeah. So I think the risk of thrombosis in patients with COVID-19, so far we don't understand the exact magnitude of the risk. But at least in patients who are not admitted or admitted not in ICU, the risk would not be that large. And therapy may continue as standard of care. In patients who are admitted who have severe enough COVID-19 to be admitted to ICU, I think a serious consideration of holding their tyrosine kinase inhibitor should be considered. Especially if they have really good molecular responses. Now, outside the tyrosine kinase inhibitors and outside CML patients, those patients have higher risk being in ICU and probably now being with COVID-19 would warrant standard DVT prophylaxis. But this is not really related to the tyrosine kinase inhibitor.
Thank you, Dr. Murtadha. So we will move to the next talk, which will be given by Dr. Naif Aljohani from King Faisal Specialist Hospital, who will try to address AML and COVID-19. Dr. Naif, the floor is yours. Dr. Naif, you are mute. Dr. Naif, you are mute.
Can you hear me now?
Yes, thank you.
Okay. So just bringing the slide up. Okay, so thank you, Feras, and can you hear me very well, or I have to raise my voice?
We hear you well, thank you.
Okay, so thank you, Feras, and the Society for the invitation. So my talk is really different from Murtadha talk. I think the impact of COVID-19 will be significant for acute myeloid leukemia patient compared to CML patients, because those patients, they need admission for a few weeks and multiple intensive chemotherapies. So I'll go over mainly I will focus on the management aspect of AML during admission and the outpatient treatment. As Feras mentioned, it's a pandemic all over the world. Most of the countries are affected, more than 1.7 million now affected, and we are part of this world. In Saudi Arabia, as you can see, the major outbreaks are in the major cities of the country, where the cancer center is usually given. for acute myeloid leukemia patient. 83% of the cases concentrated in provinces where usually AML patients are treated. And that will have a high impact on the management of those patients. So I think the effect will be in different aspects. One of them is shortage of hospital beds. Some hospitals now, they have COVID patients, and they are going through different levels of surges, and that will limit the beds for acute myeloid leukemia patients in some hospitals. There will be also limited access to outpatient clinics and infusion areas in those hospitals. As Murtadha mentioned, also there will be limited access to AML drugs. We may run out of some of the important drugs for acute myeloid leukemia due to supply chain issues and restriction on international travel. Definitely, there will be, as many saw in the media, there is significant shortage of blood products, and I think this is one of the main issues in the management of AML patients, because you want to make sure when you accept a patient or rehab patient that you want to induce him or give him intensive chemotherapy, you want to make sure you have enough blood product supply in your blood bank before proceeding. And that's going to have a huge impact, unfortunately, in the next several weeks for those kind of patients. There is also the other issue of impaired access to transplant for AML patients who need transplant or indicated for transplant, likely because of the restriction on transplant because of bed situation or because of donor issues, screening, and access to hospital for both recipient and donor. And definitely psychosocial consequences for patients with AML whom his or their treatment might be delayed or postponed for the reasons we mentioned. So those are the main, I think, facets of or aspects of how AML patients would be affected in different ways. One other important thing is AML research. I did a quick search in clinicaltrial.gov, and I looked specifically for acute myeloid leukemia clinical trials. As you know, AML, really we don't have major progress in terms of overall survival for AML in the last few decades, and this pandemic will have impact on research. When I looked for AML clinical trials that they were suspended, 42% of those suspended because of COVID pandemic. So there is a major impact on clinical trials enrollment. In terms of case reported, this is a very nice resource in ASH website. It shows you the different hematological malignancies that were reported to be infected with COVID-19. For acute myeloid leukemia, as you can see, there are a few cases reported, and this is a nice database that is freely available, and you can access it quickly, fill the form and send it to ASH, and they can put that in the statistics to share with the community of hematologists. So there are a few cases of AML reported to be infected with COVID-19. In terms of management, those are the two main and I think most important resources: the National Cancer Institute in UK, the British Guideline, and the American Society of Hematology COVID-19 resources. And those really contain really detailed guidelines on different aspects of treatment and management of hematological malignancies, including AML. So I recommend to go to those resources if you have a patient having AML. In general, the management, that were mentioned as a general points in those two different guidelines. Strictly, you need to follow your hospital infection control guidelines, use PPE as instructed or as advised, limit your physical encounters with patients as a treatment team, and practice physical distancing, and as outpatient, try to convert your clinics to virtual clinics. This is very important and highlighted in the two guidelines, the British and the American, that you need to test every AML patient prior to admission or prior to any start of the cycle, including consolidation chemotherapy, and definitely prior to transplant too, if your patient goes to transplant. Admit your patient in a single room, and it has to be COVID negative area, and strict visitation to AML patients when they are admitted, or maybe completely stop visitation, and transfuse only when you have a symptomatic AML patient. Lower your transfusion threshold as much as possible, and try to use growth factor whenever applicable during the management of AML. So I contrasted two guidelines in a table. I'm going to go through them quickly. The British and the American guidelines. We'll take them item by item. So the first one is the induction part. So the British, they use the DA as induction regimen, which they suggest to go ahead with intensive induction chemotherapy for AML patient. This is for both young and elderly patients, if it's an elderly and fit patient. This is for favorable and intermediate risk patients. In UK, they use, and in some other centers, they use Mylotarg too for favorable and intermediate risk patient, and they suggest to give them a single dose of Mylotarg if available in your center. For adverse or secondary AML, the recommendation to give them CPX-35-1 if you have it available. If not, then you will use the intensive chemotherapy of DA. There was, in the British guideline, there was emphasis on using venetoclax-based regimen for patients with NPM1 mutated FLT3 negative AML. And mainly the recommendation comes because venetoclax-based regimen usually less myelosuppressive compared to 3+7 or DA, and can give you excellent results in the NPM1 mutated AML. Or if your patient is more than 50 years old with comorbidities. That's for the AML, the favorable intermediate and poor risk AML. For APL, recommendation is to choose ATRA and ATO rather than using the ADA protocol. And the British suggest to use it even in high-risk APL patient, to use ATRA and ATO. I know many centers, they use it anyway, but some centers may still use ADA for high-risk APL patients. For relapsed AML, try to use targeted therapy. That's the advantage of having less transfusion requirements, and maybe will buy you more time to take the patient to transplant. If you don't have a target, if there is no way you can give targeted therapy because of no availability, or if there is no genes to target, then if you use a flag IDA, for example, the recommendation is to omit idarubicin and go with the flag only. Maybe that will lead to faster count recovery and will limit the product use for blood. If your patient is not fit for intensive chemotherapy and you want to use non-intensive chemotherapy for induction, then consider not using azacitidine or RSC if the patient has non-proliferative AML, or even if you're having AML that is stable in terms of count, you may try to use hydroxyurea, buy more time to have more resources available, rather than going ahead with azacitidine and RSC right away from the beginning. And for ASH, the American Society of Hematology, they mention induction chemotherapy intensive should be still offered to eligible patient with 7+3 or similar, but they did not provide more details about specific subtypes of AML. Try to utilize your outpatient virtual clinic post-induction rather than keeping your patient as inpatient. Mainly that will increase resources and beds for more AML patient. Utilize your video conferencing if you have the technicality of that. If you discharge your patient, make sure that they are on the antimicrobial prophylaxis. They talked about APL. They agree with the British guidelines for using ATRA and ATO for low and high risk APL and not going with anthracycline. For relapsed AML, their statement is to salvage intensive reinduction to be considered, but potential benefit must be weighed against the risk and with discussion with the family, and also looking at your resources available in your hospital. And they mentioned the same thing about non-proliferative AML, relapse or de novo AML is to try to not use any chemotherapy and try to treat the patient with hydroxyurea that will limit the usage of blood products. In terms of consolidation, the British suggest to reduce your dose of the high-dose RSC. Probably some centers they already use 1.5 grams rather than 3 grams of cytarabine for consolidation. And there was a lot of emphasis on utilizing MRD. If you have an MRD facility for AML in your hospital, if the patient is negative after 2 cycles of consolidation, you may omit the 3rd cycle of consolidation if your patient is MRD negative. ASH statement, you should continue to be offered the consolidation to patient in complete remission, but consider decreasing the number of cycles to 3 instead of 4, and lowering the dose of cytarabine to 1.5. So it's about a similar recommendation to the British guidelines. Very quickly, I'll touch on transplant because some high-risk AML, they will need transplant. The indications really the same as we know for AML patients. High-risk AML, different according to the ALN guidelines. The British Society of BMT and also EBMT and the American Society of Transplant, all of them suggest that you need to have cryopreserved stem cells before you start your conditioning chemotherapy during the COVID-19 pandemic. This is very important because you may, run into issues during your conditioning and transplant, and you may not be able to get the stem cells product on time. Especially this is important with a related transplant. Then you should have that as a backup to recover the bone marrow of the patient. So that's a very important recommendation from different societies for BMT. In terms of going ahead with transplant or postponing transplant, British, they recommend to try to choose and select your patients who may be at lower risk of having complication from COVID-19, which is usually the young patients or patients with the comorbidity index of less than 3. Those are kind of probably better to be selected over elderly patients or comorbid patients, just trying to mitigate the risk of having COVID in your floor and then infecting those patients who might be at higher risk of mortality. Non-urgent transplants or transplants for benign disorders, they should be postponed. And that includes also autologous transplant in APL patient and autologous transplant for myeloma patient. For lymphoma patient, you should proceed with transplant case by case if you have all the available resources. And both societies, American and the British, agree with that. The EBMT also suggests that when you decide to go ahead with a transplant for AML patient, you need to isolate the patient 14 days before starting your conditioning and test him for sure before starting your conditioning for COVID-19. And in case a transplant patient gets COVID-19 before the transplant, you need to defer the decision to transplant for about 3 months is advisable. And minimum is 21 days if you have really very high risk AML patient that need to transplant. The minimum to wait is 21 days from recovery of COVID-19, but ideally it should be 3 months as per EBMT guidelines. That's really the management in general. In case your AML patient infected with COVID-19, you should follow infectious disease specialist recommendation and your local hospital guidelines. Thank you.
Thank you, Naif, for excellent talk. I will take two questions and then we'll leave the rest at the end. So we have a question from Dr. Khalid Bakhit. For relapse refractory AML, do you think there should be no code during COVID-19 pandemic, especially treating them? I mean, they do have a higher chance of going to ICU, and there will be an expected shortage in ICU beds.
That's a difficult question. I think you have to take it case by case. What's your intent of managing the patient, relapsed AML patient? If your intent is cure, like someone who's young, you have a family donor available, sibling donor, and you have all the resources available, you should not put him no code. I think you have to go ahead with the transplant pathway and try to find the resources to help you with going ahead with the transplant. But on the other side, if the patient, like very elderly patient or someone unfit, or if you don't have a sibling donor available, I think the decision to go ahead with intensive chemotherapy versus something less intensive chemotherapy is case by case, but probably personally I would go with something less intensive if the transplant is not the pathway, something like Vidaza based or venetoclax based. And if the patient doesn't respond to your first line of therapy, then you may think about code status at that time if the patient failed more than one line of treatment.
Thank you, Naif. So last question here is from Dr. Panitos. He's saying that NCRI and ASH recommendation does apply for both COVID positive and COVID negative. Shouldn't there be a differentiation in how to use them?
So say it again, you mean COVID-19 positive AML patient?
So NCRI and ASH recommendation does not differentiate between if the patient is COVID-19 positive or negative. I mean, when it comes to
no, if you have someone, if you have an AML patient who is infected with COVID-19, you cannot go ahead with intensive chemotherapy. Mm-hmm. You'll have to treat them first and try to manage with whatever you can, like hydria, blood product support, take him through the COVID infection, and then he has to recover for some time, probably for a few more weeks. And then with the help of the infectious disease specialist who can maybe clear him to proceed with your induction regimen, then you can proceed. But you cannot go ahead and treat him if he is infected.
Thank you again, Naif. By this, I will move to Professor Wendy Stock. So Professor Wendy Stock is one of the renowned physician scientists in acute leukemia and specifically in ALL. She is from University of Chicago. If I want to introduce her, I will need 5 minutes to just to say her CV and affiliation, just to save time. Dr. Stock, the floor is yours.
Thank you so much, Feras. Can you see my slides?
Not yet.
Oh, shoot. I'm doing this wrong again then.
So the green button.
Yes, I did that.
Again, the green button, then you have to scroll down between the options.
Okay, hold on 1 second. Sorry. I don't see the green button. Hold on, I'm sorry. So sorry.
Oh, that's fine.
My biggest challenge is the slides, getting them up.
Do you see the green button?
No, I don't at the moment. That's my problem. I don't see it now. Let me see, Zoom.
What do you see exactly in the screen?
I see your face, and that's it. And I don't see anything else. I see my slides on my screen, and I said share, but it didn't work again.
No, if you just, do you see the green button?
No.
Okay, let me see. I can share it from my side if that will be if that will be fine with you.
Totally fine with me. Thank
you. So I'm gonna I will mute myself and then you the floor. So I will just move the slides.
Okay, thank you so much, and I apologize. Thanks for doing it. So I'm just going to today talk about a little bit about improving outcomes, and at the very end, I hope to talk a little bit about the COVID-19. You've heard a lot about it, and we have some recommendations for ALL as well, although they're just really suggestions because each patient is so different. Feras, I'd like to thank you and the whole Saudi Society and Pfizer for sponsoring me, and we can go ahead. My next slide are my disclosures, if you wouldn't mind. Okay, and then these are my disclosures on this slide. And the next slide, I have my objectives of the talk. And really, I've shortened it because of the timing. And I'm not going to really be talking about the TALL or CAR-T today, but really sort of talking about frontline therapy for precursor B ALL in primarily. The next slide, just a few introductory points. Until about 2 decades ago, really, we treated all adults with acute lymphoblastic leukemia in the same way. They were based in general loosely on pediatric regimens, and we achieved high remission rates. And of course, risk was based on cytogenetics and age, and many eligible patients received an allogeneic transplant in first remission. Next slide, please. These are the outcomes from the CALGB, one of the cooperative groups in the United States, from these earlier time point eras of treatment. And overall, you can see that about 41% of patients with ALL, adults with ALL, were long-term survivors on CALGB protocols that moderately replicated pediatric regimens. But you can see in the yellow right next to the purple box there, the older patients, where only 12% of patients really were able to achieve long-term survival, which is certainly not adequate. And so what I'm going to talk about today are how we were moving forward in both the younger and the older adults with ALL to make things better. Next slide, please. So this is what I just said. For pH positive ALL, we really have made some changes that result in huge differences in outcome since the kinase inhibitors came forward. And we've also really been using methods to detect minimal residual disease to improve our prognostication. But our overall treatment approach for precursor B and TALLs has not changed that much until 2010. And even though we tried to intensify certain drugs, we probably weren't intensifying the proper drugs. And we were intensifying daunorubicin and cytarabine, and that really didn't improve outcome at all in our cooperative group studies. And there's a reference to one of those studies that I led a number of years ago. But the next slide, please. Just to go a little bit into minimal residual disease, which has become probably one of our most important factors for determining outcome and helping us to sort of tailor therapy for our adults with ALL. You can see here in this meta-analysis that was done that the detection and presence of MRD in the lower curves for both event-free survival in pediatric and on the right in adult is so much worse than if no minimal residual disease is detected. And really, this is true at whatever time point that you look at. It may be best in adults to look at a later, slightly later time point, about 3 months into treatment, but this shows a tremendous, tremendous stratification based on detection of minimal residual disease. And those patients, those adults who have no detectable MRD, actually do very, very well, as you can see here on the right. Next slide, please. As I mentioned a moment ago, the detection of MRD really is independent of the type of method that you use, flow cytometry, PCR, and now there are these clonoSEQ next-gen sequencing techniques that are exquisitely sensitive, regardless of ALL subgroup and regardless of ALL time point. And this slide just shows you that MRD detection, no matter when, no matter whom, no matter what method, is very prognostically significant. Next slide, please. So we know that for patients who have high levels of MRD, higher levels of MRD, who are still in remission, they don't do well. And the slide I just showed you demonstrated that from that huge meta-analysis. This is a study that was done by the French, and it shows that patients with MRD in that blue circle, the lower curves, really are the ones who benefit from transplant. And although it would be best if they didn't have MRD, those who went forward with transplant, who had MRD in that gold curve under the blue circle, had a better outcome than if they were MRD positive and didn't have transplant. Conversely, those patients with low-level MRD, represented there by the two curves on the top and that red circle, suggests that there really isn't a great benefit for transplant if you are MRD negative at early treatment time points. And so really achievement of MRD negativity should be our goal, because then we would have good outcomes and really maybe not need to go forward at all with an allogeneic transplant, which has its own risks for sure. Next slide, please. So what we've done is learn from the pediatricians, and we've beginning to treat our young adults as if they were children. Next slide, please. There are a number of studies that show this. This is a beautiful study done by the NOPFO group, the Nordic countries cooperative group, and they show here that they've treated patients age 1 to 45 years on the exact same treatment trial. And the treatment was stratified by risk factors and by MRD. But basically what they show here is that even if you're up to 45 years of age and you're treated according to an intensive pediatric protocol, you do very, very well. And you can see the green bar, you're not as good as the children yet, but the event-free survival at 4 years is 74%, which is really quite excellent compared to what we were talking about in previous generations. This is a really lovely study. Next slide. This is the study in which I participated and which I had the honor of leading for our cooperative group in the United States. And this was a regimen taken directly from the pediatricians in the United States. It was taken from the AALL0232 trial, led by the Children's Oncology Group. It's exactly the same regimen. And you can see the different modules of treatment here: induction, consolidation, interim maintenance, delayed intensification and maintenance therapy, and the duration of the maintenance therapy. This is exactly what the pediatricians had done a few years earlier. And we decided that because we weren't doing very well in our adult world, and because we had shown that retrospectively young adults did well when they were treated on pediatric protocols, we thought, let's treat all young adults, actually up to the age of 40, on this regimen. And we did that. You can see here on the left, next slide, the next slide shows that on the left, we now have the historical controls with an overall survival rate in our 16 to 21-year-old population of only 46%, compared to that historical control, the Children's Oncology Group, of 67%. And if you click again, on the right now, you can see that for the 10403 trial, ages up to 40, we've done a lot better. This is a survival curve. And if you click again for us, you can see that the overall survival is 73%. So really, we've gone from overall survival of 46% to 73% in a more recent trial using an identical pediatric regimen, which is a huge improvement for us. Still not nearly as good as the children, but we're getting there. Next slide, please. In this trial, which was just presented at ASH, we showed that patients who were treated on the regimen that I just showed you, the 10403, and this is not a perfect comparison, but compared to patients who were transplanted in the CIBMTR registry, in the same age range, 18 to 40 years of age, in first remission, that the outcomes for the patients treated on a pediatric regimen were better. This is not a perfect comparison, but it shows a big difference. If you use a pediatric regimen, your outcomes are better and may obviate in general the need, not in all cases, but in general, the need for allotransplant. Next slide, please. Importantly, we come back to the issue of minimal residual disease, which means everything really in ALL. And here in the 10403 trial, again, just like in that meta-analysis, if you were MRD negative, and here this analysis was done after induction therapy, if patients had undetectable minimal residual disease using a quantitative PCR test, the 3-year disease-free survival was 85%, statistically significant. And so our goal, as I've been saying over and over, is to try to get more patients MRD negative early in treatment. So how are we going to do that? Next slide, please. The problem here is, as I'm sorry, on the previous slide, but you don't have to go back, is that only 40% of our patients are in that 85% survival range. So we have 60% of our patients who don't achieve MRD negativity that we really need to do better for. So now we're going to talk about immune targeting for ALL in the young adult population to try to improve our rates of MRD negativity. Next slide, please. So there are a number of trials that informed our choice of antibodies for frontline therapy. This one is the Tower trial, which resulted in approval of blinatumomab, the CD3 CD19 bispecific engaging antibody. And this trial, which was done in relapsed patients, showed, next slide, a significant benefit to blinatumomab over chemotherapy. This is again in relapsed disease, and you can see that 34% of patients achieved an a complete response. Click one more time, please, for us. And that 76% of those responding patients and 48% compared to 48% with standard of care achieved MRD negativity. So here in the relapsed population, a reasonably high response rate and a very good MRD negativity rate with blinatumomab. And blinatumomab got approved for relapsed disease, but it's something that we've considered moving forward in the front line, and we'll talk about that in a minute. Next slide, please. The other drug that we've been considering is inotuzumab ozogamicin, the anti-CD22 conjugate. And when I had the pleasure of visiting Saudi Arabia recently, it was when your country was just getting approval to start using inotuzumab about 2 months ago. So now you've had probably experience with the drug. And in a 1-to-1 randomization, which resulted in the drug getting approved, compared again to standard of care. Next slide, please. The patients had an 80% CR/CRI rate, and of those patients who had an 80% CR rate, 78% of them were MRD negative after treatment with inotuzumab. The orange curves just represent the standard of care arms, not nearly as good. Again, this resulted in inotuzumab approval for relapsed disease, which you now have that approval in Saudi Arabia. And it gave us the idea that perhaps we could use this drug early in treatment and really get MRD negativity quickly. Next slide, please. So now what we're doing is moving these agents into the frontline therapy for B-ALL. Next slide, please. Oh, I'm sorry, just click. What we're doing is incorporating blinatumomab and inotuzumab into frontline treatment. And for TALL, which I don't have a chance to talk about today, there are discussions ongoing of potentially using daratumumab to target CD38 in a minimal residual disease setting. But I don't have time. I'm happy to answer questions about that. Next slide. We already knew that adding antibody therapy to frontline treatment with rituximab showed a benefit. This is from the large GRAL French study, and it showed that in patients who were CD20 positive, Rituxan improved event-free survival in a statistically significant fashion. Now, the problem with rituximab is that only about 25% to 30% of precursor BALL leukemias express CD20. So it's not the perfect antibody. When it's there, it seems to be a useful, when the antigen is there, rituximab seems to be useful. Next slide. Now we have our new tools, our new CD19 and CD22 antibodies that we can use to try to erase minimal residual disease. There's already been one trial that resulted in approval of blinatumomab for treatment of MRD, and that's the BLAST trial, where patients were in a hematological remission, but still had detectable MRD, and the endpoint of this trial was MRD response after one cycle. Next slide. You can see here that the vast majority of patients on this slide, who, especially those who were in first remission and MRD positive, achieved a complete MRD response of 80% of those patients, in 80% of those patients. Next slide. And here's the long-term follow-up of those patients on the BLAST trial who were MRD positive after getting chemotherapy, then received blinatumomab up to 6 cycles, and their relapse-free survival without censoring for transplant or blinatumomab or post-blinatumomab chemotherapy is shown here. So there are long-term survivors here. The problem is we don't really know who's who so well in this slide to see whether or not you can avoid transplant in these patients. But next slide. Here you can see that those patients who achieved a complete MRD response did really, really quite well. And over 50% of them seem to be long-term survivors, depending on what they got afterwards. And that's the big question right now. What did they get after blinatumomab? But the point being that blinatumomab achieved MRD negativity in large number of patients, some of whom then went on to experience long-term disease-free survival. Next slide. Interestingly, in their supplemental material for the paper that was published, they showed really here that there was not a big difference in those patients who got blinatumomab and didn't go to transplant versus those who did go to transplant. And you can see the survival curves overlapping. Now, this is not powered to determine the benefit of transplant, but it shows you that potentially getting a targeted antibody in an MRD positive state and then becoming MRD negative might allow avoidance of an allogeneic transplant. So there have been a number of trials going on in the United States to really sort of further explore these issues. The first trial is the E1910 trial, which is completed now. It has enrolled over 500 patients, and it really asks the question of whether you could add blinatumomab initially in a randomized fashion, and after the approval of blinatumomab for treatment of MRD in a non-randomized fashion, whether or not blinatumomab made a difference in event-free and overall survival. We won't know the results of this study. It was completed last fall. We won't know the results for a while, but this one will help us particularly see what the effect of blinatumomab was in the front line, and then whether or not these patients were able to go on with either intensive chemotherapy or allotransplant, and how they did in more detail with larger numbers of patients. Next slide, please. Oh, you gotta click again. I gotta click like 3 times, I'm sorry. So again, this is the introduction to the frontline trial in young adults with ALL, again showing you that MRD negative remissions resulted in MRD negative remission after induction resulted in extraordinarily good outcomes. And so the question for the A041501 trial, which is the successor to the young adult trial that I presented earlier, is whether or not early addition of inotuzumab right after induction therapy can get more of those patients, the 60% of the patients who are still MRD positive after induction, whether it can get them into an MRD negative state and then move on to more chemotherapy. Next slide. So the A041501 study is really the same as the 10403, but there's a randomization, as you can see here. The patients get induction therapy, and then they're randomized to either receive 2 cycles of inotuzumab or no inotuzumab, and then the 10403 consolidation. The major change in this trial is that rituximab is being added to all patients who express CD20 in a non-randomized fashion. And this trial is ongoing now in the United States and has enrolled about 120 patients out of a total of about 350. Next slide. Our goal is to improve 3-year event-free survival to 75%, not from 60%. Thank you. Next slide. So here it is again, the schema with exactly the same blocks of treatment, little modification to them, and 2 blocks of inotuzumab or not, and addition of rituximab. Next slide. Now, you might say, well, that's great for the younger patients, but can you extend this approach, exact approach, to older patients? And the French have kind of shown us that probably using an intensive pediatric regimen in patients over the age of 55, as shown here, is not a good idea due to toxicity. And whereas patients under the age of 55, you can probably, with some modifications, get by with a very intense pediatric regimen. That doesn't mean that the older patients cannot receive these regimens, but there will have to be significant modifications made. And I don't have time to talk about that today, but we can certainly discuss if there are questions as to how one might do that. Next slide. Instead, we're looking at some other things for our older adults. And in some ways, I find this the most exciting area of all because we have so little to lose and so much to gain. As I showed you on my very first slide, ALL survival in older adults was less than 10 to 15% at 5 years. So now the idea will be to add these new antibodies in the front line of treatment and try to reduce toxicity of intensive chemotherapy and get good results. Next slide, please. So here's a published paper from the MD Anderson looking at the use of inotuzumab with minimal doses of chemotherapy, low doses of cyclophosphamide, vincristine, and dexamethasone, called the mini CVD regimen, no anthracycline in this regimen, given to older adults. And you can see here with reasonable follow-up now and in 52 patients with a median age of 68 years, the CR rate was extremely high when the INO was given in combination with this mini CVD, and the overall response rate was 98%. So really, and you see a flattening of that survival curve at around 50%, which is pretty impressive compared to 12%. So giving us the idea that maybe using minimal doses of chemotherapy with these new antibodies will bring us a long way in our older adult population. One has to remember that intensive intrathecal therapy must still be administered in all of these studies. Next slide, please. So one of the other trials that was presented at ASH recently was a trial looking similarly at even less chemotherapy and using blinatumomab in the front line of treatment. Just blinatumomab and dexamethasone, induction, consolidation with blinatumomab, and then the standard maintenance therapy with prednisone, vincristine, methotrexate, and 6-MP. This is a trial that was presented at ASH by Anjali Advani, and again, a very high CR rate of 66%, and good estimates early on at disease-free and overall survival. And I'll be interested to see what the longer-term follow-up of these studies of the study was. But if you notice on this slide, these are very small numbers still, but the vast majority of patients who were treated here became MRD negative after the blinatumomab. Next slide. And the most minimalist approach is now being taken by the US intergroup. This is a study led by the Alliance, and it's for older adults over the age of 60, and these patients will get no standard chemotherapy whatsoever. They will be getting just inotuzumab induction, followed by blinatumomab consolidation with intrathecal chemotherapy. So this is really, we've gone from tons of chemotherapy to less chemotherapy with antibody to just antibody-based chemotherapy. And we'll see how we do in our older adult population. Next slide. So here we have the summary, really, that outcomes for the young adults have improved by adoption of pediatric regimens, that achievement of MRD negative status is the key prognosticator of survival, and that really we know from the antibodies in the relapsed and the MRD setting that they achieve high response rates with MRD negativity. And therefore, these new trials in the young adults have incorporated these agents into the front line, and we'll really hope to see a significant improvement in MRD negativity and thus improved event-free and overall survival. And in our older adults, we're trying to limit treatment intensification by really using minimal doses, or now you could see maybe not even any standard chemotherapy in the front line. So that's my summary of my talk. Now, Feras had asked me to just mention in a few moments the ALL management during COVID-19. This is really just a series of summary slides. The link is on the slide here. This was put together just about a week ago, 10 days ago now, by colleagues. I was honored to be asked to lead this effort, and I found it very challenging because really it's so difficult to know how to advise. We're all just learning about this pandemic, and I can share some of my personal experiences with two of my patients here in Chicago at the very end in the question session, if you like, one of whom has ALL. So for next slide, please. I'm sorry for us. For the induction therapy, what we've recommended, which is a little different, I think, than what has been said so far, is that we felt that it would be very important, if available, to test for the COVID-19 prior to initiation of intensive therapy, regardless of symptoms. Of course, that's dependent on the testing availability. And if tests are not available, they're becoming more readily available here now in the United States, but there's still not enough testing done. And there's still not enough reagents. The tests are there, they're not enough reagents, including the swabs, including the materials to make RNA out of, make cDNA out of RNA. So if testing is not available, we recommend to get a chest CT if they're symptomatic, because they're easy to get, they're quick, and the machines are easier to do, apparently, at least in our hospital, than a standard chest x-ray. And if positive, in other words, if the patients have positive COVID, to delay systemic therapy if possible, and you might give IT chemo if CNS symptoms are present. If there is no COVID-19 and or patients are needing therapy, absolutely needing therapy, which I would hope that if they're seriously ill, you could not proceed with treatment, but you would proceed with induction chemotherapy for those patients who are not ill, not infected. And we felt that standard induction was important because this is a curable disease, and the need for ICU admissions during induction are very low, less than 3% overall, even in the adult population. And one other suggestion was that once, if their counts have not recovered after all myelosuppressive chemo has been administered, one could consider use of GCSF to facilitate count recovery. For the pH positive patients, we suggest TKI with or without steroids favored over aggressive multi-agent chemotherapy for initial treatment. Next slide. For the post-remission therapy, which again is critical for cure, we recommend in non-infected patients with proceeding with potentially some modifications. If you're using a pediatric regimen like the ones I showed you, there's a lot of low-dose cytarabine that's given, and we can prepare that. Our pharmacies can prepare it for sub-Q or intravenous injection at home for home administration to avoid coming to clinic. There was a lot of discussion amongst the group about administration of rituximab. Some felt it should be given with monitoring of IgG levels and possible replacement if patients were extremely low with recurrent history of infections, but others were concerned about giving rituximab since it caused patients to come to the clinic more frequently for long periods of exposure to nurses and other patients. We did recommend that Neupogen or GCSF at the end of each module of post-remission therapy is given to minimize the periods of neutropenia. And then very individualized decision-making, as was said in the previous talk, regarding transplantation is necessary, really to hopefully defer transplant if it's not urgent during this epidemic. Next slide. During maintenance therapy, which is really the majority of time of treatment for ALL, we recommended to try to stay on course during maintenance therapy. We know from the pediatricians that keeping the ANC low is associated with improved outcome. So we're not so keen on just saying, oh, don't try to myelosuppress patients at all, because that may impact their survival. But we thought maybe it was reasonable to keep the neutrophil count slightly higher. Most of our protocols currently say around 750, and here we say maybe around 1,000. Again, just a suggestion. And others had suggested potentially dose reduction of the glucocorticoid in maintenance and or of the vincristine, since in many European centers, neither drug is administered during maintenance therapy. In the European trials, often it's just 6-MP and methotrexate. We also suggest, similar to the other talks, to minimize clinic visits by mailing medications to the patients and following as much as possible via telemedicine and home blood draws, which is one of the things that we're doing here in Chicago. If the patient develops COVID-19, we would hold all therapy until infection resolves. Next slide. This is my last slide. Hydroxychloroquine does not interact with methotrexate or 6-MP, but be wary of using hydroxychloroquine with other QTC prolonging agents like levofloxacin and or azithromycin, which many centers are now testing for treatment of COVID. So just to be aware. And then Kaletra, which is readily available since it's an old HIV drug, but has been of marginal or questionable benefit in this infection, can increase methotrexate concentrations, and monitoring is suggested without empiric dose adjustments. But there is a very strong interaction with vincristine, and a dose reduction should be considered if you're giving that and still giving chemotherapy, which to me I would try to avoid giving any chemotherapy if a patient is that actively infected that they require these medications. There is no dose modification needed for 6-MP, daunorubicin, or pegosparaginase. So with that, I'd like to close. Thank you very much, Feras, for being my slide monitor, and click the next slide, which just has my colleagues' acknowledgements with colleagues around the world and my colleagues here at the University of Chicago. And I'd be happy to take any questions. Thank you very much.
Thank you, Prof. Stock. So you answered, so we'll go now to the Q&A session, and you already answered one of the questions, which was, shall we do COVID testing for any patient who will receive intensive chemo? And the answer is yes.
If possible. Yeah. I don't know what your situation is like in Saudi Arabia.
Well, we do the same actually for any patient who will be going for intensive chemo or bone marrow transplant. It's we have to say, even the donor actually for the bone marrow transplant, we're securing the donors. Okay.
Testing is available here in Saudi. We don't have issues.
Yes, Dr. Naif.
I think Wendy's question was about testing availability.
What is the testing availability? That's a great question. It changes literally here. It changes on a daily basis. And a lot of it has to do not so much with the ability of the lab to run the analyses, but on the reagents that are required, including something as simple as the nasal swabs, which have been in short supply, and also the material that one uses, the kits that are used to convert RNA to cDNA have been in short supply. But suddenly now, in the last week or so, I would say that the limitations are slowing down, at least here in Chicago. It's so variable all over the United States. And so I really, it is still very risky. And that's why I was saying, if you can't, at least maybe screen by looking at a chest CT to see if there's any hint of anything. But we are trying very hard to test, and what we're doing for the transplant patients, for example, is having them come, we have this drive-by area where they come by to get their swab 2 days before, and we are collecting all the donors, like you said, ahead of time. But for the inpatients, we have to screen them when they come in, like the AML and the ALL patients who come in emergently, the new diagnosis. So we're testing them. They're being isolated in negative pressure rooms until those results come back. And then we either go forward or try to delay treatment, depending if they're really sick with COVID.
Dr. Stokes, so there is a question from Dr. Khalid Bakhit. He's asking, during such a pandemic, would you change IA maintenance phase to reduce patient visit to the hospital and emergency?
That you mean the IM phase where you get the one day you get the methotrexate and one day you get the asparaginase? Yeah. That's a great question. We have not changed it, but that is a great question. You know, I still think that that's preferable over, for example, substituting that with high-dose methotrexate, which is an option, but then that would require admission to the hospital and several days of admission for hydration, high-dose IV methotrexate, and IV leucovorin. So we have not changed that. Now, if there's any way to delay cycles a little bit, maybe that's a good idea, but really we're very worried about making too many broad recommendations since these patients are curable, and we really want to try to maintain their trajectory of moving towards cure.
Okay,
great question, though.
Another question from Dr. Abu Harbish is, what's the impact of COVID-19 now in your hospital admissions?
Yeah, that's a great, well, Chicago, you may or may, I doubt that you get the up-to-date moments, although you certainly know a huge amount about the pandemic. Here in Chicago is one of the main, Chicago is a hot spot for COVID. Our hospital on Friday, I don't have the numbers from the weekend or today yet, but about for the whole last week now, there are about 200 patients in our hospital, 100 and on Friday, 110 with COVID, definite, 80 or so under investigation, about 20 patients on ventilator of those. Looks like in Chicago right now from the weekend, the incidence seems to be peaking. And here, I'm sorry, I'm just gonna turn, sorry, I can't turn it off. The incidence seems to be peaking, and so we're hopeful that, and the admission rate in the last several days doesn't seem to have gone up that much. But so Chicago is not nearly as overwhelmed at this moment as a place like New York, where it's just been shocking to me, the number of deaths. In Illinois, I think there are 600 deaths so far, the state in which I live, and there are about 20,000 cases already in Illinois, the state in which I live, most of them here in Chicago.
That's very sad, and it's all over the world, actually.
Yes, yes, it is. I can
So
tell
I have a
you
question.
very quickly about my, oh, go ahead. I was just going to tell you about my one patient with ALL, if you want.
Yeah, please proceed.
This guy is 32 years old, and he had just gotten his first month of maintenance chemotherapy, according to that 10403 regimen. He is MRD negative. He called me about 3 weeks ago, said he had a dry cough, no fever. This was when it was still relatively early here in Chicago. That was on a Tuesday. And then on a Thursday, he said he was more fatigued and the cough, still no fever, his cough was getting worse. So we were able to get him to come here, and we were able to test him as an outpatient. And he then went home. A few hours later, test came back positive. So I asked him to purchase by mail a pulse oximeter to measure oxygen saturation and to monitor. And he was doing okay for about 5 days. Then his fevers started to get fevers over the weekend, and they started to get really high. And I was getting worried because he told me his oxygen saturation, which was around 98%, was down to 96. And his fevers were up to 103. So I had to arrange to get him admitted, which was a challenge in and of itself. He was our first leukemia patient with COVID admitted. And he got admitted. We have a special unit. He wasn't on our leukemia unit. 3 floors of our hospital are now COVID floors exclusively. And he was on one of those floors. He's being taken care of actually he had been taken care of by a special team, not the leukemia team. We were only consultants because we're not allowed to go onto the floor. And he really was never that hypoxic. He was, as the most oxygen he was ever on was 3 liters, but we had treated him, by the way, with hydroxychloroquine and Kaletra, both at the very beginning. And then we continued the hydroxychloroquine. I don't know whether it made a difference or not. We don't know, obviously. And then his fevers and diarrhea were really the problem. And his fevers were as high as 104.5, which is crazy. And he got 1 dose of tocilizumab about 6 days into his hospitalization. And eventually he got 2 doses of anakinra. And the anakinra, the IL-1 receptor antagonist, really knocked out his fevers. And he went home a week ago Monday. He was in the hospital for 12 days. And he went home safely. And he's now feeling much better. I haven't seen him yet. But that is my one ALL experience. Of course, we stopped all of his maintenance therapy. And interestingly, the virus, his white count was about 2,000 when he came in, with about an but he was very neutropenic, and there was a huge debate, and I don't know interested to hear what you guys are saying, that there's a huge debate amongst our team and amongst specialists here about whether or not growth factors should be given during an active infection because it might increase the inflammatory response. And so we avoided giving GCSF. I don't know if that's right or wrong, but that was the recommendation.
Okay. Just for the time's sake, we'll try to go quickly over some questions. So Dr. Boharbish is asking, what's your average length of stay, Dr. Stock, for acute leukemia induction? How long do you usually do it?
We keep them until their counts recover. So it's usually about 3 weeks, 2.5 to 3 weeks.
And another question from Dr. Aljohani. He's asking, for older adults, will you be adopting mini-hyper-CVAD plus inotuzumab as standard of care during COVID pandemic?
That's a good question. I don't know the answer to that from my own opinion. I don't think that's the wrong thing to do for frontline therapy. I was also thinking maybe in this setting to use inotuzumab as a single agent and avoid potentially the myelosuppression. This is just totally my opinion. And so we haven't had such a patient yet, but we do have that trial, which, as you might imagine, is on hold at the moment, where patients are going to get just inotuzumab induction. So I'm hoping that perhaps we would be able to get the drug and do that. The mini CVD plus inotuzumab would be a very reasonable thing, but maybe you could even avoid myelosuppression more by not even giving the VD.
So another question, Dr. Stock, is from Dr. Dada. Any preliminary result from the study of 041501 trial with inotuzumab?
No, I just have my own. No, there are no preliminary. We haven't looked. There hasn't even been a look at the data. I could just say that my own experience has been that it's very well tolerated, and that in my own patients have been doing very, very well on the trial, and the ones who've gotten inotuzumab have achieved MRD negativity quickly. So that's encouraging. But it's just like those are my own patients. We haven't looked at the data at all. There's only 120 out of an expected accrual of about 380.
Excellent. I will be switching to Dr. Naif for AML questions.
Sure.
Dr. Naif, for a low-risk acute myeloid leukemia in remission post-induction, will you elect to offer azacitidine instead of high-dose RC to avoid during COVID-19 pandemic?
Low risk, what?
So AML?
I meant favorable risk AML, right?
Yeah, favorable AML and CR1 post-induction. Will you consider changing the consolidation with AZA instead of high-dose RC?
Well, that's a good question. Maybe, I mean, again, I don't have an answer. I think it depends on the circumstances in your hospital and the resources available. I mean, favorable risk AML, usually you like to give them a good dose of RSC, and probably you may reduce the dose and give them 1.5 gram for accelerated count recovery, better than azacitidine, just a personal opinion. But I mean, you could do either way. I think they should be okay.
So there is a question from Dr. Wael Anizi. He's saying he has a 17 years old AML, favorable AML. He is post-induction and 2 cycles of RSC. He's in location with chromosome Y and extramedullary disease. Asking you, would you offer him PMT now because there is no matched donor, or you will proceed with high-dose RSC?
That's a good question. You know, extramedullary disease in A21 AML is very controversial and contradicting results about poor prognosis. So you gave him 2 cycles of high-dose RSC. I think if you don't have a matched sibling donor, probably you would not proceed to transplant at that time, especially during those times of the pandemic. So probably I'll continue with chemotherapy, especially that there is no matched sibling donor.
Okay. There is another question regarding the donor. I mean, AML who will be going for transplant, and what precaution shall be taken for the donor. So the recommendation for, ASPMT and EBMT recommend, and WMDA recommended cryopreservation for specifically for MUD donors before transplantation, and the same thing to be considered for matched sibling, if you especially if the donor is not living in the same city with the recipient. However, I mean, personalization is needed. Depends on so Dr. Murtadha, there is a question about cardiac complications of TKI. Do you do routine echo as follow-up?
I'll be guided by symptoms. Now, before COVID, I'll be guided by symptoms, and we don't routinely do it. you may consider it if you wanted to start dasatinib, and there may be a touch of symptoms that may suggest cardiac. Now, during COVID, I would still not do it unless I'm guided by, unless there are symptoms that hint towards cardiac complication. Now, I mean, all of the assessment would also be guided by the volume of COVID in your center. So currently, and maybe in Saudi, is the areas of high prevalence of COVID or high incidence of COVID are the same as the cancer centers, similar to Muscat, but here we see some hospitals are more affected by the other hospital, and you will be guided by this in your hospital. Currently, at least at the university hospital, we still don't have that volume. One second about CML patients, as I said, the impact in CML is way less than the impact in AMLs and in ALLs. This is mostly outpatient, and this is single agents that we think, at least what the data suggests now, it does not immunosuppress, it does not increase your risk of COVID complications.
Thank you, Dr. Murtadha. Another question regarding interferon in CML and the antiviral effect of interferon. Will you consider it as an additional treatment for new CML or relapsed CML during COVID-19 pandemic?
I would try to avoid it for sure, just because if someone on interferon and gets COVID-19, they likely would get way more complications. The second thing, it would interfere with the diagnostic of the symptoms. And again, there are many other options that are better than interferon that we currently have now for CML patients.
Excellent question, answer. So there's an excellent question. So it will be for all the panelists. So is there a role for CAR T cell in treating COVID-19 or gene editing to treat COVID-19? Any comment from the panel?
Well, no comments means nobody knows, I guess.
We don't. No, I was going to say the same thing. I don't even know if the virus results in some unique antigen expression on the surface of the cell. That would be important. And so I can't imagine it might cause so much respiratory damage that I can't actually even imagine that being a viable idea, because you would be killing, you're not killing lymphoid cells or myeloid cells, you're killing lung tissue and other tissues. So I don't think we know, but I don't think that would be, it sounds like a vaccine would be a better idea, or serology, antibody.
So, sorry,
yes, Murtadha.
I mean, to prepare it, it would take a long time for you to give it to a COVID patient, and it may add to the cytokine storm. And the target tissues, as Prof. Stock said, is probably the lung that may produce more damage.
Okay. So
I have a question to Dr. Stock, if it's okay for us. Quick one.
Yes, please.
Yeah.
Yes, please.
Did you guys use any plasma infusion for your COVID patients?
We haven't done it yet, to my knowledge. I know that they were beginning to do that at one of the other. I know they've done it in New York. I don't know the results. I know that they've tried. They've collected serum from recovering patients and infused it, I think, in an emergency situation. And I think at Rush, which is one of the universities here in Chicago, I think they're doing something similar, but I don't know in our hospital if that's been done yet. I think it's a cool idea, but I think that we don't yet even know how to measure the antibody titers and who would be a good donor. But I like the idea a lot. I like your idea a lot.
Dr. Stuck, another question. Do you use blinatumomab routinely post-induction for MRD eradication? And
I
to
don't.
avoid
I mean,
transplant?
that is a great. I mean, I think if somebody was not on protocol, I wouldn't do it right after induction, but I would do it if somebody was not on a protocol. I would wait until the end of consolidation therapy, because that's the time point by which, at that point, patients have received all of the chemotherapy drugs that the sort of all the ones that they're going to get. And so by then you'll know whether or not the disease is truly resistant. The Germans have showed that that's the most important time point for measurement of MRD. But if you were still MRD positive at the end of consolidation, the answer is yes. I think that's a good idea to use blinatumomab. Now, can you avoid transplant? That's a different question, and I don't know the answer. It looked like from that one study that maybe if you go on with some other treatment, maybe go back to your post-remission therapy and then maintenance therapy, you could avoid transplant. But I think giving blinatumomab alone and stopping all treatment, I think the chances might be high of relapse, and I think we just don't know. So I would definitely use it as a way to get people MRD negative before continuing with some other treatment or moving forward with transplant, which I think is, at this moment, the more standard approach in those MRD positive patients.
Thank you, Prof. Another question about MRD. In your hospital, what do you use, molecular or flow? And what level?
Yeah, so that's a good, our hospital lab uses flow, and it's about 10 to the minus third to 10 to the minus fourth. I would say 10 to the minus fourth. Now, we have recently, my own lab, my research lab, does quantitative PCR testing, but that's just for the clinical trials. And for commercial use, what we've just started to do, and it's kind of a big, it's a little bit of a hassle to set up, but we are using this lab in Seattle, Adaptive Biotechnologies, and they do this next-gen clone-specific PCR, and they can get a level of 10 to the minus 6 to 10 to the minus 7. And they can track multiple clones, which is kind of cool. So I've had a couple of cases where our flow in our lab is negative, but the MRD there is positive. Now, is there a difference, in those patients? Is that important? And it looks like from one little study that was published from the Children's Oncology Group that if you're negative by flow but positive by this clone-specific technique, you do have a slightly higher relapse rate. Not as high as if it's again by level. And so little bit is still detectable, is still not a good thing. So we're starting to use that more regularly. It's pretty expensive. I don't know. Do you guys have that in Saudi Arabia? Can you send it for this next gen sequencing PCR?
For the MRD, you mean?
Yeah.
Yeah, so we are doing it in our hospital flow cytometry.
Yeah.
We do NGS, but not for the MRD, like for mutation.
Yeah, that's only I think the only FDA approved one here in the United States at this moment is this company called Adaptive Biotechnologies.
Okay, we're going over the time, so I will take only two questions. So there's a comment actually / question from Dr. Benitios. He's asking about Philadelphia positive ALL and the use of TKI. Whether this will be an additional risk for COVID-19 infection.
To be on the TKI, I think.
So TKI, he's saying, is known to have an effect on the T cells.
Dasatinib in particular, I suppose. But I still think that I don't think I would stop. Similar to what was said earlier for CML, I'm not sure I would stop treatment just to, especially with Ph positive ALL, just to minimize the risk of COVID. I think obviously if the patient had infection, active infection, you would stop and hold the drug for a while.
The last comment from Dr. Ali Al-Ahmari, it's for the all panel. analyst. He's saying, does chemotherapy protective against cytokine release syndrome 19 related? So are our patients, I mean, are less prone or have less risk of illness? Any comment from that?
I think that's a really interesting question, and I don't know the answer. One of our infectious disease guys thought that maybe because my patient was so myelosuppressed that he actually didn't have as much inflammatory response, but he still had a pretty big one. And I have another patient who was post-allo. He wasn't getting active chemo though, but he was very immunosuppressed. So I can't answer that question, but I think it's an interesting question and a good one. I don't know the answer.
I think we are already 25 minutes beyond the time.
Oh, I'm sorry.
I would like to thank all the 110 attendees who joined us today, and I would like to thank all our renowned experts, specifically Dr. Prof. Stock, Dr. Murtadha, and Dr. Naif for their great contribution. I would appreciate if everyone fill out the evaluation form that they will receive when they exit the Zoom. And thank you so much.
Thank you very much.
Thank
Bye,
you.
everybody. Good night.
Good night.